Good morning to all the delegates. Myself, Dr. Rakesh, consultant in critical care, KIMS Hospitals. So I'd like to thank Dr. Sambit sir, who is my teacher, Dr. Venkat Goyal sir, Dr. Sunil Pupani sir, and Dr. Pranay Ojha sir for giving me this opportunity. So today's my topic is sedation and analgesia in ECMO. So generally, for all the happiness mankind can gain, they define the happiness as it's not a pleasure, but it is rest from pain. So anyone who doesn't having pain, that itself is called happiness. So today's learning objectives. So we're going to briefly discuss about what are the guidelines saying to us regarding the sedation analgesia. Is there any validated scales to measure those things like pain, sedation, delirium? What are the limitations and benefits of drugs that are presently available? And what are the modifications should be done whenever you're using these drugs in case of a ECMO? So coming to the sources of pain in case of ICU and ECMO, there are so many sources like surgeries, lines, ICDs, catheters, ET tube, pre-existing conditions, frequent suctioning and sampling by nursing staff, and immobilization in bed. So what happens is if this pain is there. So these consequences like sleep deprivation, agitation, splinting, and stress response. So these are the various consequences of pain that delay the recovery of a patient. So these pains will stimulate your autonomic nervous system, leading to tachycardias, hypertensions, your myocardial ischemias, and there will be hyper or hypocoagulabilities. There will be immunosuppression for the patient, and there will be severe psychological disturbances like delirium, post-traumatic stress disorder, anxiety, and hallucinations. So, what are our goals? What are our goals for sedation analgesia in a patient of ECMO? So, our goals being decreasing the pain and anxiety of the patient, decreasing the stress response of the patient, while decreasing the oxygen consumption as much as possible, because the calm and sedated patient's oxygen consumption is very low. My patient ventilator synchrony should be maintained, and by doing all these things, we are avoiding the neurocognitive sequelae in ICU, like case of depressions, post-traumatic stress disorder, dementia, and anxieties. Much more important thing, it's the family acceptance that comes into play whenever the patient is completely sedated. So we need to have sedation interruptions for the patient to communicate to the family, so that the patient also feels much more calm and cooperative to you in an ICU. So coming to how to assess this pain, whether the pain is present or not, it's purely a patient response and it's a self-reporting. To measure the intensity of the pain, we have several scales available: verbal rating scale, visual analog scale, numerical rating scales, and behavioral pain scales. I think most of you are the intensivists here. I'm not going in detail about these scales. Just behavioral pain scale is one thing which most commonly used. So it includes three variables: facial expression, upper limb movements, and compliance with the mechanical ventilation. Each variable is given a score of 1 to 4, 1 being completely accepting, 4 being completely or is agitated patients. So this behavioral pain scale ranges from a score of 3 to 12, 3 being no pain, 12 being the maximum pain. So the target in our ICU being 3 for all the patients. And where this delirium comes from for the case of a patient inside an ICU, there are so many factors that is contributing to the development of delirium. It may be a drugs, it may be a chronic hypoxia, or it might be a it might be a metabolic derangements of the patients. It might be systemic diseases, and it might be some toxins that are causing these things. It might be because of metabolism, decreased metabolism, and it might be because of any organ failures, like in case of hepatic NKF, conditions and all. So these are the various sources of delirium. So once the delirium develops, you need to assess the delirium. There is a tool called CAM-ICU tool, confusion assessment method for the ICU. It includes a 4-step process where the first step, you are assessing the patients on a daily basis. Is there an acute change of mentation that happened compared to the previous state or previous baseline state? If it is there, yeah, we have to go for step number 2. If it is not there, the patient is negative for delirium. If it is there, means then you have to ask the patient, attention of the patient should be tested. So something like you should ask the patient to hold your hand or press your hand whenever a letter A comes. Okay, say like then you have to say some word which having more number of letters like A. So you should ask the patient to squeeze your hand whenever the letter A comes. So if there is 0 to 2 errors, that is most common. If there is more than 2 errors, yeah, the patient is having some kind of delirium and all. You should go for the next step. Next step is the level of consciousness, which is assessed by means of Richmond agitation sedation scale, the target being 0. Okay, if it is target is 0, then you should think for the next step whether there is a disorganized thinking, that is there any, I mean, like patient's coherence is lost. Whether the stone floats in the water, is the fish in the sea. So the questions like this should be asked. If there is also positive or more than one error is present, then the patient is considered as delirium present. So you're supposed to treat this patient for delirium, and you should identify the causes for this delirium, and then you have to remove the identifying factors. I mean, you should remove the causating factors also. So coming to the guidelines, the Society of Critical Care Medicine. So these guidelines will give us a brief, what is the directions, how to do, how to maintain the sedation and analgesia in a patient. So depth and quality of sedation should be routinely assessed in all the ICU patients. RAS score and Riker score are the most valuable scores, and sometimes you have to use objective brain function tests rather than always a subjective measurements like EEG monitoring, and then EEG monitoring should be done for all the patients where the suspicion of NCSC activity, which is generally missed in all these patients in a critical ill patient. Target the lightest possible sedation, or always you can use daily sedation interruptions. And every ICU should have a sedation protocol and checklist before administering the sedations. So always try to use non-benzodiazepines rather than benzodiazepines. So I'm going to tell it why, because in the next slides, the scoring systems, as I'm mentioning before, this helps to monitor the depth and quality of our sedation. It should be easy. These scoring systems are actually simple, easy to monitor. These are non-invasive and reproducible. There are most commonly three scoring systems are being used inside the ICU: Richmond agitation sedation score, Riker scoring systems, and Ramsey scoring systems. So this is Richmond agitation sedation score, which comes a score from, it ranges from -5 to +4. Where +4 patient is very combative and -5 patient is in deep coma. Target is being 0. We need a patient who is alert and calm. When it comes to Riker sedation agitation score, the scale is again ranging from 1 to 7. 7 is being dangerously agitated, 1 is being deep coma. The target for Riker score is being 3 to 4. So patient should be calm and cooperative, or patient should be sedated. So this is our target. Coming to Ramsey scoring system, it ranges from level 1 to level 6. Level 6 is completely coma, level 1 is completely awake patient. So we need a target of around 2 to 3 is the main our target. So the patient cooperates to all your treatment, cooperates to ventilation, those kind of things. So these are the main scales that are being used inside an ICU. As I mentioning before, measurement of brain activity is an objective test. Okay, it should be done in all the patients where there is high chance of NCSC, and in some patients who are receiving neuromuscular blocking agents. So that's also should be taken into consideration. So there are so many, I mean scores which are used inside an ICU or operation theater, which includes a bispectral index, EEG. You can use an evocable potentials. By mixing all these things, they produce one score called bispectral index. This index, which includes the patient safety index, narcotrend, and cerebral state index. So this bispectral index, as I'm quoting, the scale ranges from 0 to 100, 40 to 60 being the anesthetized patient, then will the target instead in OD. So for our ICU patients, the target being around 80 to 90, because patient should be like mildly sedated, patient should be awake and all. If you want moderate sedation, the target should be around 60 to 80 again. So another thing is this EEG is generally, as I'm quoting, it should be generally mentioned, I mean, done for all the neuro ICU patients and then patients who are at high risk of developing this NCSC. So what are the targets by doing all these things? You should attain the lightest possible sedation in a patient, or as I'm telling, it should be use a daily sedation interruption strategies. So these daily sedation interruption strategies allows better sedation needs assessment of the patient with better sedation needs, and it reduces the drug bioaccumulation, reduce the incidence of post-traumatic stress disorders and all the neurocognitive sequels, reduces critical illness, and ventilator free days can be increased. So coming to specific type of drugs, what are the drugs that we have that comes under the sedation therapy? It's broadly divided into pharmacological and non-pharmacological. You should always think something that whenever the patient is complaining of pain, it's not the drugs that is the treatment and all. You should think some non-pharmacological treatments also, whether some simple communication reassurance, making the patient meet the attenders, and environmental control like the humidity, lights, temperature that's making the patient agitated and all should be controlled. Management of his thirst, hunger, and full bladder, which are generally addressed, but still, this management of this thirst, hunger, and bladder also will decrease the patient's pain and anxieties. And prior explanation of any procedure that is going to happen on the patient shall bring his anxiety levels very much down. So always think that there is some non-pharmacological measures also. No need of sedation for every patient inside your ICU, especially if the patient is very much cooperative. Coming to pharmacological, keep in mind before initiating the pharmacological therapies, make sure all the reversible causes are ruled out. The patient comorbidity should come into your mind like OSA, COPD, what are the side effects of the drugs that are being administered for this patient. So after ruling out all these things, you should choose a pharmacological agent. So how to choose it? An ideal pharmacological agent, yeah, it should have both sedative and analgesic. It should have anxiolytic, amnestic, and anticonvulsant properties. Minimal CNS, CVS, and respiratory side effects, and it should have a rapid onset of action and a rapid offset. No accumulation should happen in case of hepatic or renal dysfunctions. It should not have any active metabolites, and it should be less interactive with any other drugs which are commonly used inside an ICU. I know it's difficult to find an ideal agent, but our target is to reach an agent that is near normal, it's like near normal to an ideal agent. So coming to pharmacokinetic concentration of drugs, and you should always keep in mind what is the patient fluid status, volume of distribution of the patient, serum protein levels of the patient, is there any renal and hepatic dysfunction happening for this patient. So generally the drugs which we most commonly use in ICU for our sedation and analgesia in a patient, they're broadly classified into analgesics, sedatives, etomidate, other drugs, random drugs, and regional anesthesia techniques. We try to avoid these regional anesthesia techniques in case of ECMO especially, because all these what do you say, thrombocytopenias, all these things will not allow us to do frequent regional anesthesia techniques. Coming to specific drugs, the classification of opioids, so many classifications are available for the opioids in the books. So basically this classification divides them into semi-synthetic, synthetic, and natural analogs. Natural, you all know, morphine, diamorphine, and codeine. And semi-synthetic and synthetic agents like pethidine, fentanyl, methadone, pentazocine, okay, buprenorphine, these are all semi-synthetic and synthetic agents which are available inside our ICU. So I'm going to discuss about the most commonly used drugs. I'm not going to discuss about all the drugs here. Time is very short. So morphine, fentanyl, and hydrocodone are the most commonly used drugs. The advantages I'd like to discuss: the morphine, the onset of action is around 5 to 10 minutes. Fentanyl has got the shortest onset of action, 1 to 2 minutes, and the infusion rate is also very less, 7 to 10 micrograms per kg per hour. So, but the only disadvantage with the fentanyl is the lipophilicity, and it is 600 times more lipid soluble than morphine. Keep it in mind. And fentanyl does not have any active metabolites compared to its congeners morphine and hydrocodone. And histamine release action is also not there for fentanyl. And when it comes to renal failure, there is no dose adjustment required for in case of fentanyl. And for morphine, you should decrease the dose by 50%. So let's see which drug is superior to incoming slides. So coming to remifentanil, which is an ultra short acting drug, it requires a continuous infusion, 1.5 mics per kg bolus followed by 0.5 to 1.5 mics per kg per hour infusion. And this analgesic effect stops within 10 minutes of stopping the drug. So metabolized by actually non-specific esterase which is present in the plasma. So there is no need of dose adjustment for these drugs in case of hepatic failure or renal failure. It's most useful when frequent neurological monitoring is required. So whenever you want the patient to be awake, you can keep these patients on remifentanil infusion, but it is very hard to find this drug. It's not that much common. Coming to tramadol, it acts via mu receptors, which causes some sort of sedation thing. It inhibits the uptake of serotonin and noradrenaline with presynaptic stimulation of serotonin release. It is generally used in moderate to severe pain. The dosage is being, everyone knows it, 50 to 100 mg every 6 to 8 hourly. You can go a maximum up to 600 mg per day. So what are the side effects of all these drugs, opioids? Okay, so all the common side effects of these drugs being vasodilatation, hypotension, constipation, respiratory depression, confusion, and abstinence syndrome might develop. If it is a receptor type, no, mu1 receptor is generally the desirable effect which causes our analgesia. Mu2 is a respiratory causing depression, respiratory depression, constipation, euphoria, and addiction. Delta receptor will cause hallucinations and delusions, and K receptor mediated action will also have analgesic sedation and meiosis. So our desirable effects come from mu1 and delta receptors. Coming to other non-opioid analgesics which are present inside our ICU might be your ketorolac, ibuprofen, and acetaminophen. Of all the three, most commonly used is acetaminophen. Coming then next is ketorolac. I think brufen, so many people have stopped using these things. The advantage of being acetaminophen administering for analgesic is it can go up to full doses. It's given at 1 gram 6 hourly. It does not have any anti-inflammatory effects, and it has a much more side effect profile. Only thing is, whenever the patient is landing in hepatic failure, be careful with the accumulated dosages. Okay, so the maximum dosage per day should be decreased when the patient is landing up in hepatic failure. When it comes to ketorolac, it has got very good analgesic action, but it's actually an NSAID. It has got anti-inflammatory and antipyretic effects. Serious complications are generally less likely for a short-term usage, but if you are using it for a long term and daily, then you should always think of renal dysfunctions, GI bleeding, decreased platelet activity with these non-opioid analgesics. Coming to benzodiazepines, These drugs, there are so many drugs that are available in this group. These drugs are anxiolytics, amnestic, anticonvulsant, hypnotic, and minimal muscle relaxations, and reacts to GABA receptors. They depress the excitability of the limbic system, and these drugs will have higher volume of distribution, slow clearance from the body. So they have minimal CNS and CVS and respiratory side effects. So for all the drugs, I'm quoting the three. I mean, like I'm comparing three drugs here: midazolam, lorazepam, and diazepam. I think midazolam, every other IC will have all the three drugs here. So for all the three drugs, if you can notice it here, I think I'm not going in detail with the dosages and maintenance dosage. I think everyone has to think of in by heart these dosages. So coming to main advantage and disadvantage, midazolam has got a shortest action 1 to 5 minutes. Okay, and the duration is also very short for midazolam 2 to 4 hours. And the longest acting in this group will be your diazepam that acts around 3 to 11 hours. The cardiac side effects is minimal here. And only advantage again, midazolam is having its amnesia. It's a potent amnestic agent which does not, which no other congeners will have this amnestic action in this group. And it, but the problem is it has got some active metabolites, midazolam. The side effects are severe hypotension might happen in a patient who is already vasodilated. So another coming to other drugs or miscellaneous drugs, propofol, which acts through GABA mediated activity. There is no need for bolus for these patients. So only infusion is practiced in case of a propofol that's specially inside an ICU. The maximum can go up to 4 mg per kg per hour. As I'm quoting, it's a rapid onset 1 to 2 minutes and can accumulate in infusion dosages. When the context sensitive half-life is longer for propofol here, and it's a short-term agent. You cannot use it for long-term inside an ICU. And this propofol will cause increased triglycerides and cholesterol levels and PRIS syndrome. Propofol infusion syndromes might happen, but especially in case of pediatrics and neonates, actually, this thing. And side effect profile is very high. That's why this propofol is not generally used as a sedative or analgesic drug inside the ICU. So as I'm telling, propofol infusion syndrome, when you're using dosage of more than 4 milligrams per kg per day for more than 48 hours, patients will develop this propofol infusion syndrome. I think everyone is aware of it, but I just want to refresh your memory. This propofol infusion syndrome will cause bradycardias, cardiomyopathies, rhabdomyolysis, metabolic acidosis, hyperkalemia, and renal failure. And you should have a high suspicion of doubt for these things. Any patient who started on propofol within 48 hours or more than 48 hours, if is developing the above features, you should always think of propofol infusion syndrome. Treatment is nothing. There is no specific antidotes are available. Only thing is a supportive care. Coming to ketamine, yeah, this is one more emerging drug that's emerging inside our ICUs and ECMO patients. It's an NMDA receptor antagonist. It prevents nitric oxide synthase release. At subanesthetic doses, it is sedative and analgesic also. But the main disadvantage is it stimulates your sympathetic activity. It raises your blood pressure, heart rate, intracranial pressure. So everything is increased here. And it's used as a bronchodilator in case of an asthma patient inside your ICU, but it should be always used in conjunction with other narcotics. Okay, it doesn't cause, generally it's not that much sedative, and the dose is being 50 to 30 micrograms per kg per minute. So there are several other drugs which are like etomidates, barbiturates like thiopentanol, sodium. We generally use this for burst oppression or a patient is having throwing an active NCAC. And volatile agents can also be used like anaconda, which delivers isoflurane or desflurane. And two most common drugs generally used it might be your atypical antipsychotics like haloperidol and quetiapine. So these mainly used to decrease the chances of delirium in a patient. And as any patient is, if the patient is experiencing any hallucinations inside your ICU or an ECMO patient, so these drugs are generally used, but the side effect profile is very high. Make sure like you're not using any QT prolonging drugs in combination with quetiapine, like all these ondansetrons and quetiapine. This combination is dangerous, and sometimes you tend to use these beta blockers and even evaporating also to decrease the heart rate. So all these drug interactions are very high with these antipsychotics. So the usage is generally limited. Once you're very sure the patient is in delirium, then only use these drugs. So alpha 2 agonist. This is actually a very good drugs that are emerging inside our ICU. I think so many ICUs are right now using these agonists. So we have clonidine and dexmedetomidine here. These are centrally acting alpha 2 agonists, which causes sedations. The alpha 2 activities is much more for dexmedetomidine, and the advantage is T half is very less here, only 2 hours. But the disadvantage is only available in IV form. Clonidine is available in all the forms, but clonidine is primarily it's an antihypertensive. It's not an analgesic or a sedative. So dexmedetomidine is used as an analgesic and sedative. And the biggest disadvantage of dexmedetomidine is highly protein bound, and it is only a very short. So I'm going to tell you what. Now coming to specific considerations in case of an ECMO. See, we have learned about these drugs. We have learned about the guidelines. What we learned about the scales. I mean, how to measure your sensorium and all. But when it comes to ECMO, there are some specific factors which you should consider before administering a drug, and you should know that how the drug acts in a patient on ECMO. So, what are the various factors, considerations, or specifically in case of an ECMO? It is the lipophilicity of the drug you should keep in mind. It's a protein bonding nature, volume of distribution and drug dilution, vasodilated states, tachyphylaxis, sepsis, combination of many drugs inside in ECMO patients, and decreased blood flow to specific organs in case of VA ECMOs, circuit components, multi-organ involvement, and sepsis as encoding. So these are the various considerations you should always keep in mind, especially in case of an ECMO. Coming to individual level, lipophilicity. See, the drugs that are which are more lipophilic, which is measured in terms of your octanol water partition coefficients and log P values, these are more prone for sequestration inside the circuit. So more the lipophilicity, more the drugs get attached to the circuit, lesser is the action. So there are so many studies conducted by Shaker et al., Mehta et al., and all these studies were demonstrated significant loss of drug levels inside the circuit within first 24 hours, especially for example fentanyl. So they demonstrated fentanyl was consistently losing in the circuit. 97% of the fentanyl dose that had been administered as lost in the circuit within first 24 hours of usage. In another study, they quoted that fentanyl is only stable for only for 3 hours, but undetectable at 24 hours. So once you're giving only fentanyl as a boluses and all, know that the effect of the fentanyl will not come for the patient. So you might be thinking that you're sedating the patient, but actually the patient is not sedated. All the drugs are being eaten away by the circuit. So keep in mind, more the lipophilicity, more drug requirement is required, more dosage of the drug is required. So this is the graph depicting the levels of the drugs after 24 hours of administration. Surprisingly, our morphine, which is less protein bound and less lipophilic, it's maintaining its concentration level still 24 hours after the, inside the circuit. When it comes to midazolam, there is a drastic decrease in its level. When it comes to fentanyl, there is completely, this drug has not been identified in the circuit after 24 hours. Coming to protein binding, yeah, the same thing. The more the drug is protein binding, the drug gets more sequestered in the circuit. So if it is both lipophilic and protein binding, the drug is not at all seen in the circuit within 24 hours. So all the examples like propofol, fentanyl, midazolam, so these are being proven by Hyman et al. And Lemaitre et al. Studies. You can go and refer those studies. So all the drugs that are more lipophilic and protein binding, there is, the drug will get significantly lost in the circuit. So what you have to do, you have to adjust the dosages a little bit. So they need a higher initial loading dose with a higher daily dosing regimens to reach the saturation of the receptors, because unbound drug is the one which is more pharmacologically active here, because all the drug gets bound to the circuit. Your unbound drug is very less here. So to increase that, you need to increase your initial loading doses and higher daily dosage. The infusion dosage also should be increased. Coming to the volume of distribution and drug dilution, generally it's not important for all the adult ECMO patients. It is much more important for the pediatric and neonates, because the volume of distribution or extra dilution that you're adding with the circuit is almost 100 to 50% in case of neonates or pediatrics. Where it comes to adults, it's only 20 to 25%, because you're hardly adding 700 ml of priming solution inside the circuit. So more the volume of distribution, more drug dilution happens. Drugs need to be administered in high dosages, high bolus dosages. Okay. So it's also being affected by means of protein burning, because this albumin which is present in the body is completely, coated to the circuits, and also your albumin is lost. So once the albumin is lost, there is very much less amount of albumin available in the body. Okay. So there are so many other factors like circuit factors, SIRS response or third space response, increased permeability of all your blood vessels that leads the albumin loss. As I'm telling, it's more important in neonates and pediatrics. Okay, coming to vasodilated state. So ECMO, ECMO, it's a state of a full multifocal sepsis and shock. It leads to a vasodilated state with a higher hemodilution values. So these patients, they are more prone for exaggerated responses to opioids. Already these are in vasodilated state. Even if you give 1 mg or 2 mg of midazolam, these patients will go into severe hypotension kind of thing. And even the routine antihypertensives will also cause severe hypotensions. So make sure that before administering, what is the status of your patients, and decrease blood flow to specifically organs. So when it comes to decreased blood flow, especially in case of VA, what happens? The drugs with high first pass metabolism to the specific organ, say for example lungs, drugs like inhalation anesthetics, opioids, they tend to accumulate more. There is no blood supply, there is no metabolism, they tend to accumulate more. You might get an exaggerated sedation response in these patients. Okay, the same with renal elimination, hepatic elimination. You should know the route of elimination of all the drugs. If the drug is renally eliminated, you are supposed to decrease the dose. So Coming to circuit components and priming solution. So what are the circuit components that's affecting the dosage of your drugs? The polyvinyl chloride PVC, generally all the circuit is made up of this PVC substance. So it actively binds. What will do? It actively binds the lipophilic substances. So it's a good source of binding drugs and releasing later on. So it acts as a reservoir. Okay. So drugs binds to alkyl group of polymers which is present in the PVC tubing. More the PVC tubing, more the chance of drug binding. More the length of the circuit, more the chance of drug sequestration in the circuit and later release. And roller pumps has got much more drug sequestration than a centrifugal pumps. Okay, and coming to priming solution, yeah, it's the priming solution will cause your drug dilutional effect, but there is no actual study showing significant change in drug characteristics. So what does it do? It less cause your drug to be diluted. That's it. So you need to administer higher dosages of that. So in a nutshell, so till now what we're discussing it here is kept in this slide. So if there is a hemodilution happening for a patient, okay, you're hemodiluting a patient, especially neonates, there is increase in volume of distribution, decrease in the maximum concentrations reaching. So you are supposed to increase the loading dose, so especially in case of hydrophilic drugs like beta-lactams and aminoglycosides here. And with hemodilution, they will be increasing in the free drug concentrations. You need to increase your loading dose, increasing the maintenance dose frequency also. Generally happens for highly protein drugs like teicoplanin and ceftriaxones, and drug circuit related factors, drug sequestration. So whenever the drug is getting more sequestrated to the circuit, there will be increase the volume of distribution, decrease the concentration. Same thing, you increase the loading dose. So again, the lipophilic drugs like fentanyl, fluoroquinolones, and midazolam, we are supposed to increase the loading dose of these patients. When it comes to drug inactivation, generally, which is happening, there will be increase in clearance and decrease in the bioavailability of drugs. So you need to increase the frequency. The same with the lipophilic drugs. Coming to patient factors, as I'm mentioning, there will be surge response or sepsis. What happens? There will be third space loss. To maintain the blood pressure, you're giving more amount of fluids. There will be increased volume of distribution, decrease the concentration maximum, and increase in clearance of the drugs because the loading dose. So, what you are supposed to do? You have to increase the loading dose. Again, the hydrophilic drugs are getting affected here. So, for these drugs, we have to increase the loading dose. If it is an organ failure specifically happening, drugs that are metabolized through that specific particular organ, then we increase the volume of distribution and decreasing in the clearance. You are supposed to decrease the frequency of these drugs. So whichever the drug that is eliminated to particular route, if that organ gets affected, you are supposed to decrease the frequency because it will lead to drug accumulation and exaggerated effects. Coming to drug factors, as I mentioned about, if it is lipophilic drug, it is more circuit sequestrated, okay, and you are supposed to increase the loading dose and frequency both. If it is hydrophilic drug, it is more volume of distribution, decreases Cmax, concentration maximum attained, and increase or decrease in the clearance depending upon the function or route which is eliminated. So loading dose should be increased and frequency you should always think based on your targets. Okay, so these are the various factors that's happening that's controlling your drugs or the drug effects inside your ECMO patients. So to come down to a specific topic, as I mentioned, it's only because sedation analgesics. So this was taken from Shaker and et al. And benzodiazepines coming to midazolam, higher the octanol water partition coefficient, higher is the lipophilicity, higher the protein bound. Significant circuit drug segment drug sequestration happens inside your circuit. Same with dexmedetomidine too. And coming to fentanyl, it's highly protein bound, highly lipophilic, so significant drug sequestration happens. The morphine is one thing which is less lipophilic and less protein bound. There is minimal to moderate circuit drug sequestration happening in morphine. So if you want me to say what is the ideal drug here, the drug that reaches nearby to your ideal drug characteristics is morphine when it comes to ECMO for initiation of sedation and analgesia. But you need to adjust the dosage of remaining drugs also. Higher initial dose with higher daily dosage should be done. Propofol again is higher lipophilic and highly protein bound. So significant drug sequestration happens in these patients. So keeping all these things in mind, so what are our take-home points today? So every patient is different. So you cannot generalize the drug dosages to all the patients. So every patient is different, but keep sure that all the targets are same for all the patients. As I'm mentioning, the Ramsey scoring system should be 0, the Riker score between 3 to 4, and when it comes to other scoring, I mean, what is the other one? Which one? Ramson. So the targets, basically the targets are the same for all the patients. So make sure the targets are achieved rather than the specific drug dosages you are delivering. So every pain does not need medication. Sometimes there are some reversible causes of pain. Okay, sometimes like a thrombophlebitis, IV cannula causing thrombophlebitis. So which when you remove the IV cannula, patient will be happy, much more happy. And every patient does not settle down in sedation. See, when it comes to sedation, we cannot sedate all the patients because all the receptors gets accumulated or like completely occupied by all the drug molecules, and also you cannot settle every patient with sedation. Sometimes you need muscle relaxants also. Okay, if it is very mandate and all patient is becoming too much restless and agitated, you need to sedate and then paralyze the patient also as and when required. So don't only think of sedate and paralyze, sedate and analgesics, think of paralyzing agents, but they come with their own side effect profile, higher chances of illness, neuromyopathy and all. And every drug is different. So every drug has got specific characteristics. Make sure you know what are the characteristics that's affecting the outcomes, what are the characteristics that are affecting the target sedation levels. You should be knowing all those things. And every agitation, as I'm telling before, it's not because of the pain. Always follow a protocol based approach. So you should always have a protocol based approach. So we need further studies in this segment like ECMO PK studies and ASAP ECMO studies to understand the pharmacokinetics of different drugs which generally we are lagging now right now at this point of time. So further studies are required. And what we generally do in our patient on ECMO is like we tend to change the drugs frequently, like every second day or third day. We are trying to shift the patient from one drug to other drug. Say, for example, we started on a morphine infusion today. For the first next 2 or 3 days, we continue the morphine infusion and we try to change the drug from every second day. We'll shift down to fentanyl. Sometimes we use both fentanyl and morphine. The third day, we'll try to shift down to dexmedetomidine. So in that way, what we are doing is we're all the receptors which are got occupied by the drugs has been released again, so we can get much more therapeutic profile for the specific drug. So by doing this, we are avoiding the drug bioaccumulation and we are getting a desirable profile of the drug. So and then the reservoir with the circuit which acts as a reservoir also will be releasing some amount of drugs. So it will be all free of those things. So that is the general strategy we used to follow in our ECMO patients. Try to change the sedatives every second day or third day whenever we come for rounds, and also that in that way you can keep the patient more awake and you can have a less side effect. So it's always a tailor-made, it's never the same for all the patients. Thank you so much for all your listening.